you, ma'am. So now I would like to invite Professor Rajesh Sinha first. We are changing slightly the order of the talks because sir has another commitment elsewhere, and he'll be talking about the various drugs that we have available for different allergic disorders and the medical management essentially of how do we manage these patients.
Thank you, Dr. Ikeda, for the opportunity. And we all handle these allergic eye disease because this is something which is very commonly seen in our clinical practice. And we do encounter these patients, and we all have certain specific way of handling it that might differ. However, I will be presenting about the options and then how I approach a patient of allergic eye disease. So as was very nicely mentioned by Dr. Rishi and Dr. Ikeda, that nearly 20% of general population suffers from allergic eye disease, and most people develop allergies in childhood. However, as was being discussed just now about VKCs and the allergic eye disease, so a large majority is seen in children, but there is a certain group of patients who do have systemic allergies as well, and that they do have these allergic eye disease even in adulthood. And that is why it has been shown that the eye symptoms are the second most common allergic presentation, apart from, of course, the respiratory symptoms. And that is why people who are highly allergic, they do develop these respiratory symptoms, and then they do develop these watering and redness and papillae and allergic eye conditions. So we have to handle them. Of course, the systemic management will be done by the physician, but we have to handle the ocular symptoms, and sometimes we do have to give systemic medication as well for ocular features. So there are many medications. So we have to decide how to select, how to go about, how to make our own protocol so that that fits, and that can differ with different individuals, that can differ in different geographic conditions, that can differ with different kind of air conditions, environmental conditions, like in cities where there is more pollution and the cities where there is less pollution. So many factors are involved in managing these cases. So let me just go through a certain group of drugs, and then I will come to the protocol that I follow. So the anti-allergic drugs can be basically grouped into mast cell stabilizers. We have been using it for many years, for decades. The mast cell stabilizers, the cromolyn glycate, etc. Then topical antihistaminics, we have been using it for a very long period. Even now we have some recent antihistaminics like alcaftadine, and of course the dual acting agent have come up, which not only act as antihistaminics but also act as mast cell stabilizers. So antihistaminics, basically they block the released histamine. So they prevent the itching of the eye, they prevent the itch by blocking the histamine receptors. So once the histamine is released, then they come into action and they block the symptoms. So they are very good to relieve the patient of symptoms, but they basically work on the histamine receptors, and they don't work on prostaglandins and leukotrienes, which are some other inflammatory mediators. Then we also use vasoconstrictors like nafazoline, which is sometimes useful for symptomatic relief. Many times these patients, you have to take care of the allergy, you have to take care of these vessels as well. These vasoconstrictors, they prevent the increase of presence of inflammatory mediators there, like something like nafazoline can be, which has been used for decades now, and which is still useful, which still holds true. Mast cell stabilizers, they stabilize the mast cells, so they prevent the release of histamines. They don't work on the already released histamines, but they prevent the further release of histamines. And the dual acting agents, something like olopatadine, they work on both. They not only stabilize the mast cells, but they also work on the released histamines. And that is why these days you all will agree that olopatadine is something which is most commonly used drug for allergic eye disease, because it not only stabilizes mast cells, it also takes care of the released histamines, and it is available in various concentrations. Initially it started with 0.1%, which was given twice a day, then 0.2%, then 0.7% has come up, and that is given once a day, and that is quite effective. And for obvious reasons. I mean, this is a study which has shown comparison of olopatadine versus cromolyn, and they found out that olopatadine is more effective, and that is obvious reason because it has a dual action. So this olopatadine is, of course, the preferred dual-acting agent, and it is very effective in all sorts of allergic conjunctivitis, whether it's a VKC or it's a seasonal allergic conjunctivitis or it's a contact lens associated papillary conjunctivitis, and it has been used along with ketorolac. Now, why ketorolac? Because ketorolac works on the prostaglandins. Olopatadine works on the histamines. So it takes care of all the inflammatory mediators. If the patient has severe or moderate to severe allergic symptoms, you can use any ketorolac or nepafenac or bromfenac. I mean, all these things have been used for taking care of the allergy, because it brings about a multimodal approach, and it covers both histamine as well as prostaglandins. Of course, steroids is the final, we say, brahmastra of everything. When nothing is working in cases of allergies, we have to use steroid. Or some patients who have come with severe allergic symptoms, marked cobblestoning, you avert the papillae, you see the marked giant papillae, you have to use steroid because it is very essential. It inhibits both cyclooxygenase and lipoxygenase pathways, and it can be used by different routes. It can be used topical, it can be given systemic as well, in short burst for cases who are not responding, and it can be given as supratarsal injection in conditions wherein there is marked cobblestoning of papillae. Normally, whenever we give steroid, there's a general tendency that we should give high potent steroid so that it works well, and then we can reduce, we can taper off. But in cases of allergies, wherein you may have to use these steroids for a slightly longer period, so in order to prevent the complication related to steroid, we start with a low potency steroid, and if it's not working, then we go to the high potency steroid for a short burst, and then come back to the low potency steroids. And as I said, topical steroids, they are very effective in severe allergic symptoms, and but the risk of glaucoma and cataract is there, so you have to be careful in that. As far as I mentioned, that supratarsal injection of steroid is usually very effective. You can use triamcinolone 0.5 ml injection, evert the lid, and just go beyond the tarsus, inject at multiple sites, and you may have to inject it multiple times actually in cases of severe cobblestoning. This is still a slightly better one. We have injected, you can see the kind of cobblestoning that was there, but there can be even worse scenario wherein you may have to inject multiple times, 2 to 3 times supratarsal steroid. Only thing is you have to be careful in these patients because already you have used topical steroids, so you will be grossly aware that these patients are not steroid responders, but you still don't know. So when you are giving supratarsal steroid, these patients have to be carefully monitored because this is a depot preparation. It is a depot there and you cannot take it off. That is the thing. So that's why if there is any rise in IOP, then you have to manage it, and you don't have to think about a second injection of topical steroid, second injection of supratarsal steroid. There are certain steroid sparing therapy like cyclosporin and tacrolimus. Cyclosporin is a good immunomodulator which is available in 0.05%, 0.09% and 0.1%. So depending upon the severity, you can use cyclosporin. The biggest advantage is you can start with steroid along with cyclosporin in moderate to severe, and then you can taper off the steroid and continue with cyclosporin, because cyclosporin topically given, we had done a long back, we had done a study with 2% cyclosporin in graft rejections, prevention of graft rejection. We found out that the systemic concentration was much below than the concentration that can cause toxicity. So the commercially available drugs are up to 0.1%, so it's not going to cause any problem. And it is very effective immunomodulator. Another immunomodulator is tacrolimus, which is again very useful, 0.03%, 0.1%. And some patients, you can put it inside the eye off label. Some patients, they do not tolerate tacrolimus. So you can put it over the lid also, and there also it works. So that is the advantage of tacrolimus. And of course, tear substitutes are good because they not only wash off the allergens, but they they provide symptomatic relief as well. So in summary, if it's a mild case of allergic conjunctivitis, we can manage with a simple dual acting agent like olopatadine and lubricant. A very mild case, occasional allergy, occasional itching, etc., you can just manage with lubricant only. But if there is a significant allergic conjunctivitis, you have to use these olopatadines. If it's a moderate allergic conjunctivitis, you can use a low potency topical steroid for a short duration, taper it off. You can use olopatadine. If it's slightly moderate to severe, you can combine olopatadine with ketorolac or Nevanac or bromfenac with topical cyclosporin and lubricants. Later on, you can take off the topical steroid and continue with olopatadine with topical cyclosporin and lubricants. After some time, you can remove this olopatadine as well, because long-term use of olopatadine can also cause dry eye, which can be a complication, which of course will be discussed by Dr. Somshila Murthy. So then you can continue with cyclosporin and lubricants only if the patient is comfortable. So that will not only improve the cause immunomodulation, it will also improve the prevent the chance of dry eye. Occasionally you have to give systemic antihistaminics if it's a severe case of dry eye, severe case of allergic conjunctivitis. So you have to give systemic drugs. And if it's a marked cobblestoning, repeated supratarsal steroid is given. And of course, most important thing is that regular follow-up is essential. For people who are steroid responders, you can use higher concentration of cyclosporin. I have used higher concentration, 2% cyclosporin in some steroid responders prepared in our pharmacy, and it has worked well when used for a long term. So thank you very much once again for giving this opportunity, and any suggestion, any addition to this will be welcome.
Thank you so much, sir, for covering all the different options for management and all the different drugs and how to use it and when to use them. Do we have any questions from the audience? Yes, ma'am, please. Please come to the mic.
The next question, there's another mic also. Good morning. I would like to know that what is the youngest age when we can start these drugs, like olopatadine and all? Because now I have been seeing in my practice that some kids are coming with itching and all since 2 years, before 2 years, like 1 year of age, 2 years of age. So can we start these drugs safely for them?
We just have to see whether there's a marked papillary conjunctivitis. And if it's not marked, then we can start initially with a lubricant and see whether the child is responding or not. If the child is not responding, then we can use olopatadine in these cases, because we have to take care of allergic conjunctivitis, we have to take care of itching, and we have to prevent the rubbing of eyes, because that can further lead to complications like keratoconus, etc. So that is something that we have to take care. But yes, if it's a mild rubbing, etc., one can start initially with a lubricant, preservative free, and then go ahead along with that. Well, low potency steroid can be used again depending upon the severity. If it's not responding further to, say, you are giving lubricant and olopatadine, then we can use low potency steroid, short burst. But most of these children, usually they develop these allergies at the school going age group. Yeah. So we may start actually because we have to give a long-term therapy. So we should titrate in such a way that we start with the minimum. That is, you start with a lubricant, then we may go ahead with the olopatadine and other things.
Thank you so much.
Yeah.
Sir, olopatadine 0.7%. Is it safe in 5-year childs or?
Yes, it is safe in children as well. That's not an issue. Only thing is, the immunomodulators have not been studied in children. So immunomodulators like cyclosporin, tacrolimus, there is a question mark on that. But as far as olopatadine is concerned, it is safe.
Yeah, olopatadine is not approved for usage in age below 3 years or 2 years, something like that. So that is what it says. But it also says that the doctor can decide. So it's based on us that we can decide, as Dr. Rajesh is saying, that we can decide and administer the drug to a patient who's as young as 2 years of age, but first after trying lubricants. So this question comes because now parents themselves, they read and they say it is not approved for such a young age. Why are you giving it to my child? So yeah.
Actually, cyclosporin also is not approved below 16 years of age, but at times we have to give cyclosporin even at the age of 8 years, 9 years, 10 years.
Tacrolimus, what age is it?
Again, as I said, immunomodulators have not been approved below 16 years of age, but sometimes what happens that you don't want that much of rubbing, and as I said, off-label. So off-label use, you can do it. You don't want that rubbing, otherwise the patient will end up with keratoconus and all sorts of problems. Yes.
Just one last question, sir.
Yeah.
Sir, what happens many times 2 years children also come with lot of allergic reactions. So like you said, we just start with Olopac or Lubricant. Many times they don't respond to that, and whenever low potency steroids are added, like Pamcin is on Google nowadays, then there are a lot of reviews which come, this is not appropriate or this is not done. And still they are not handled. In such cases, what should be done?
I'm in another session.
So I can answer that because I was earlier in my, till recently practicing at LVPI, where patients don't challenge us or anything like that, sorry to say. But now I am temporarily moved to Mumbai, where every patient comes being a Google doctor or a ChatGPT doctor. So every patient, especially for their children, they're very, very hesitant to use something that says steroids. So it takes a lot more counseling, and then we explain that the theoretical risk of this drop, you know, getting absorbed systemically, causing some growth retardation for your child. That's what steroid, imagine Lotepred 0.2% or whatever, going theoretically into the body and causing growth retardation. That risk is so low as compared to the child chronically rubbing the eye, at least developing cosmetically not good looking brown conjunctiva. That is the minimum problem, getting keratoconus. So that's how I convince those parents, the ones who...
How long the therapy should...
It is a chronic. That's the reason why for these patients, the first visit will be like a half an hour, 45 minutes, much to the disgust of my optometrist, that room is blocked for some time, because they have to have a buy-in in the therapy. It's going to be, initially when they come, I say this is for years. And it's good if it takes less than that, so that they are ready for it.
So we can continue Olopat or...
Not steroids, yeah. I'm not talking about steroids at all. Steroids, as you said, is short term. But olopatadine, and usually very soon I shift to tacrolimus.
Okay.
The ointment, yeah.
Okay. Thank you, ma'am.